So, as we get started, I think it's really valuable to know that in developmental disabilities, pain is actually an area that has been really underrepresented and under-researched. And this has resulted in a number of different outcomes that are unfortunate for us, for individuals with charge, in that they've often been excluded from research studies investigating how pain impacts their life, impacts their behavior, or even how to more appropriately identify pain in this population. So for individuals with developmental disabilities in general, there has been a suggestion that individuals need to experience a higher threshold of painful experiences to be able to feel pain. And that really has been debunked in more recent research in the past decade or so that suggests that we probably just were doing a bad job of identifying pain in individuals, and we were missing cues of what would indicate pain for them. So when you think about pain, one of the most important things to think about is its self-report. And for individuals with developmental disabilities, self-report may be very difficult depending on their communication approach or style. In charge syndrome, we've ran into the same situation where there had been reports that individuals with charge had to experience a higher threshold of painful experiences to be able to feel pain, meaning that while you or I might feel pain as it's starting to grow, that they didn't feel it until they reached some type of threshold. And I think that is a little dangerous for us to make that assumption without any data to support that at the moment. And actually what we have found in most developmental disabilities, individuals who experience genetic conditions or have atypical development often experience more chronic and more intense pain, particularly given the types of experiences that they go to, including physiotherapy, medical procedures, and long-term hospitalizations that would likely indicate painful experiences as well. So in charge syndrome, I've become an advocate to say that while we don't have a whole lot of research on pain at the moment, we don't have research to also suggest they're not feeling pain either. And I think if you meet any individual with charge, they're likely to tell you that they do absolutely experience pain, but that their way of reporting it might be a little bit different, or letting other folks know that they experience that pain could be different. So what I've hypothesized for this population in charge is that they actually experience a higher pain tolerance rather than a higher pain threshold. And I urge you to kind of think about that in the same way you'd think about if you had a backache. You don't complain about your backache every minute of every second of every day, even though it's residual pain that stays there and is pretty chronic. But you're more likely to complain or talk about or suggest or seek help for a painful experience like a backache when it makes it difficult to do your job, to get out of bed, to care for your children, to do the day-to-day activities that you and I typically would do, despite the fact that that painful experience might be there. So I do think that individuals with charge, and we're going to highlight that throughout this presentation, have a greater tolerance build up for painful experiences than they necessarily have a threshold for painful experiences. And I think that's one of the first important points we need to make for this population. So one of the first things that I think has led to this confusion about pain and charge, or us trying to understand pain and charge, is first that, as I had mentioned, historically there has not been a whole lot of research for developmental disabilities in pain. They were excluded because they thought they might experience pain differently, that they weren't able to self-report their pain. And that's really put us decades behind other conditions in being able to problem solve chronic pain, acute pain, and really how we move forward with treatment for pain for this population. So we do have a lot more work to do. However, one of the things that makes it difficult with charge to be able to measure pain are a few key areas that we have to first look at to overcome in this process of understanding pain and charge. And one is that individuals with charge, being the leading congenital cause of deaf blindness, is that as a result of those multisensory impairments, they're likely to have a different communication approach. We have a spectrum of communication abilities in this population. So we have folks who are vocal and verbal and can form complete sentences and maintain to and fro conversations, to folks who might use a communication device or sign language, or might use a picture communication system. And there's a wide variety of combinations of those things that folks use with charge syndrome. And so when you have limited or no communication approaches, or the abstract concepts like pain haven't been built into your communication repertoire, the first big problem we run into with pain research is that we want you to self-report your pain experience. So when we ask individuals with charge, are you experiencing pain? But that abstract concept hasn't been taught to them, and they don't know that this feeling is pain, that can lead to a big challenge with us understanding what pain can look like for that population. And if they can't self-report the pain experience, then that obviously adds to the fact that they might not be getting treatment as efficiently or as effectively as they could, as you or I might be able to say, hey, my pain's a 10 on the scale today. It's really bad. I think I need to go to the emergency room. That self-report is really what allows us to understand. So we have to use other cues in the environment to be able to help us understand that. And we'll talk about those in just a little bit. The other big challenge with charge syndrome is the result of facial palsy. So I would say probably 40 to 50% of individuals with charge have some type of facial palsy. When you use non-vocal pain assessments, what they're often looking at is a change in your facial expression. Are you wincing your eyebrows? Are you making a furrowed face? Are you grinding your teeth? Some of those things could be really difficult to identify in charge as a result of the facial palsy. So it's valuable for us to consider scales that consider the whole body change and a change in behavior for identifying pain in this population, rather than strictly looking at facial changes. Really, that's challenging too, because oftentimes, even when we consider babies, we look for them to wince or cry or have those types of outcomes when they're experiencing pain and don't have the communication to tell us they're in pain. But we have to modify what we look for in this population to identify pain. And then we have the abstract part of the pain experience. So we do know that in some populations, particularly individuals who are blind, they might lack social referencing or social communicative deficits. And really, as a byproduct of their vision impairment, they miss interactions in their environment to teach people about the abstract concept of pain and relating the words pain and treatment to their actual experience. So to give you an example of that, social referencing is that thing that we all have done when we were kids, where if you fell down and you were a little toddler and you look back at your parents, and if your parents, make a big to-do about the fact that you fell down and rush over and ask if you're okay and pick you right up, the child will usually start crying and have a meltdown and show their boo-boo and express that they're uncomfortable. If a parent responds in a different way, the child looks back and the parent says, oh, dust yourself off, you're doing okay, stand on back up. The child is able to realize, oh, this wasn't such an emergency, I dust off my knees and I stand back up and I go back to playing. That social referencing allows us to know sort of the severity of our behavior and how intense we should respond. And it teaches us those appropriate social communicative clues in our environment. And if we think about that with pain, I'm worried that individuals with charge often miss the opportunities to learn about pain in that same way. And because of those multisensory impairments, I also worry that from their peers or other folks that they interact with, that they also may miss that opportunity. So they don't see their peer fall down on the playground and look back for assistance and or ask for assistance. They may miss those pieces that are other ways for us to understand this concept of pain and how we're supposed to respond to it, which could make our self-expression or self-reportive pain different because you have a different learning history. So those are the first few cues that I think are really valuable for us as professionals and those who hope to work with individuals with charge to consider, is that we have to rethink about how we understand the concept of pain and how can we better teach that with very concrete and specific examples in their life, and making sure that we're doing that more purposefully rather than it sort of happening abstractly in their environment around them. Certainly, it's really important to identify pain. When we have pain that's continuous or even acute pain that occurs multiple times, this has an impact not only on neurological development, but has an impact on our day-to-day life, our quality of life, and generally our temperament. So it's really important that not only first can we identify pain so we can provide treatment and reduce that pain experience and make somebody feel better, it's also really important that we identify pain to avoid the development of problem behaviors, or what we might call challenging behaviors. there is very clear research in other developmental disabilities, for example, autism, Down syndrome, and symptoms like that, where challenging behavior will spike when an individual has a painful experience. So we see things like self-injurious behavior, aggression, pulling out of a G-tube or a feeding tube increase when that individual is experiencing a painful situation. And really what that tells me is I'm trying to communicate to you, the other person, that I'm in pain and uncomfortable, and I'm going to take this behavior as far as I need to get your attention. So hopefully you pay attention to that behavioral experience to know that I'm experiencing pain. And we want to avoid those destructive and problem behaviors, because that also unfortunately becomes really reinforcing. If, mom or dad hadn't noticed that behavior or noticed the painful experience, and suddenly I'm ripping at my skin and pulling at my face and I'm now bleeding, mom and dad are going to respond very quickly to that. And that meant I had to do that level of behavior to get that type of response. And we want to avoid reinforcing those behaviors and find other ways that child can communicate to us that they're experiencing that painful situation. So sometimes we have a good indication that a pain might be present simply by a change in the child's presentation, and severe behavior could be one of those pieces that we look for. We also know that if pain isn't treated, it could have an impact on attachment. Attachment's really important, and from a very early age in charge, one of the important things that we focus on is attachment. Babies are often left in the hospital for many months at a time. They return to the hospital very often as a result of some of the side effects of charge syndrome. And so we want to make sure that when we're working with individuals with charge, or as parents of individuals with charge, that we're taking time to recognize how attachment's developing. And if I'm always uncomfortable, that could have an impact on how well I attach to others around me. And last but not least, obviously, when somebody's in pain that we care about and that we love, that adds a whole lot of stress to the family dynamic. We want our child to feel better. Our teachers want us to feel better when we're at school and we're students who don't feel well. That added stress for everybody can be really hard sometimes to overcome. One area that my research lab is actually focusing on right now is the outcome of post-traumatic stress symptoms on parents of individuals who have a child with charge. We've spent a lot of time thinking about what the individual stress might be like for that child, and ways that we could hope to mitigate pain and identify pain in this population. But we've kind of forgot what that stress is like for a parent to have reoccurring hospital stays and to have life-threatening surgeries that occur multiple times throughout their child's life, or to think that they were at a window when those surgeries were done and now we have another one that we have to do. Those are traumatic experiences, and we want to see how our families are coping with that, because if they're not coping well, the odds are they're also not giving good coping skills for their child with charge to cope. And this all compounds upon each other and impacts how well we can identify pain and manage that pain in the future. So that's certainly an area beyond our understanding of just pain in charge and what we can do to mitigate the pain experience and improve that. We also need to think about how this impacts the rest of the family and the other folks that are involved in the life of that individual with charge. So let's move in a little bit to talk about what are some of the painful experiences in charge. I've talked about it in quite a bit of detail already, that I have a concern about the pain experiences in charge, but let's talk about what those specifically might be. And you'll see referenced on this slide that this was a published article from 2019 with Stratton and Hartshorn that was where most of this data is coming from. And this was really the very first publication that was ever presented about research related to pain in this population. We hope to have more publications in the future, but this is the start of what will hopefully be a long line that many folks would be interested in being involved in, particularly in the medical community as well. So when we think about this research study, our primary focus was to seek out caregivers or parents' input on pain for their child with charge. And we particularly took that approach because many individuals with charge are unable to self-report their pain experience or may have difficulty looking back at most recent pain experiences and giving an estimation of the duration of time that lasted. So for this first investigation, what we did was we asked parents or caregivers to identify what they felt was the most consistent painful experience that their child had, how often that occurred, and how intense it was. So what you'll see on the slide there are days per year in pain, and then you'll see the mean and the standard deviation. And our mean is the mean number of days in a year an individual with charge was likely to experience pain from this symptom. And the symptoms or characteristics that are listed there on the left-hand side are some that we had provided to parents that we knew were just common symptoms based on having charge syndrome, and others were provided by parents to us as these were concerns for their child. You'll see there's things like jaw discomfort, migraines. Those are things I believe that are related to our cranial nerves that are going to be very valuable to have a greater understanding with. And Dr. Kim Blake does a great job of discussing how our cranial nerves impact all aspects of our body. And I think some of our painful experiences generate from some of those cranial nerve dysfunction as well. But you'll see there, those highlighted in red, muscle pain, the abdominal migraines, hip and back pain, breathing, difficulty swallowing, and gastroesophageal reflux. Those are occurring at a very frequent rate for individuals with charge in our sample. And so what you see is anywhere from 95 to almost 170 days out of the year, parents felt like their child experienced that painful discomfort, which is a huge suggestion to us from this research that not only do we have acute pain experiences that might be very brief and short term, but we also are likely to have chronic painful experiences within this population that could last many days at a time or come and go often throughout a duration of time that impact potentially the quality of life of that individual with charge and could potentially mean that we need to seek treatment for that concern. And this was really telling to me in this research was that we had done years of no research on developmental disabilities and pain, and our very first study on charge was able to tell us that some of these symptoms of pain last 170 days out of an entire year. That's really important data for us to pay attention to because that also tells us what are we doing for intervention and treatment, and that's where we need to expand our research for this approach. So as you look at this chart, you see the characteristics that could be painful related behaviors on the left-hand side. In the middle column, the M is our mean or average duration per year of what that is. And our standard deviation, or the SD on the right-hand side of that table, is going to be the average amount of variance in our population. So if you look, for example, at muscle pain on average occurred 95 days or more a year, but that had a wide spread. Some individuals experienced it less than that, and some individuals experienced it up to 136 days or more. So that's sort of the duration of the amount of variance we see in the population with charge, which for many of these, you'll see there's a good deal of variance, which suggests that some individuals are experiencing these on a much more frequent basis, and for some individuals, this isn't as much of a concern in their day-to-day. Another part of what we did in this study was we used the Wonker pain faces that you can see on the screen. So these are a very common rating scale where folks take faces and try to get folks to identify 1 through 4 or 1 through 10. What is the experience like for you? This is one of the most validated facial expressions scales that is often used, so that's why we chose to use it for this study. You can see there's 0, meaning I'm having a really good day, there's no hurt at all the way to 4, which is a hurt worse that I often describe to family as that's likely like you're considering a trip to the doctor, to the emergency room because of the intensity of that experience. This is a hard, and we do recognize this, and it was a preliminary study in that It's very difficult sometimes to make a judgment call between is my painful experience a 2 or a 3, is it a 4, and that can be really difficult for those of us with very clear communication and good intent to self-report. But this was one of our best ways to try to validate what the intensity of this experience could feel like. So as you look at the graph here on pain intensity, one of the things that we're looking at, and to just get you associated with the graph first, on the left-hand side, you're going to have the characteristics of pain. The next column is going to be the mean average. Again, that standard deviation or range of variance that we see from folks' responses. And then the range, that last column on the right, is what their responses were to that facial pain scale. Remember, that had a rating from 0, where there was no pain, to 4, that hurts the worst. So what you can see here is many of our experiences had an average intensity of around 2, a 1 or 2 experience. So on that facial pain scale, parents rated their child as experiencing either a 1 on the facial rating scale or a 2 on that facial rating scale, meaning moderate pain for their child. And so when we look at some of our most painful experiences at that parents thought impacted their child based on their presentation, things like migraine, abdominal migraine, constipation, surgery pain, ear infections, even going down to sinus infections and gastroesophageal reflux, were at least rated to be a middle of the road kind of painful experience for individuals with Charge syndrome. As you can tell, there's not as much variance in what our pain rating was here in that standard deviation column. But what I think was really interesting is that range column on the right-hand side, is that, like you can see for migraine, most parents rated that a 2 to a 4. Almost nobody said their child doesn't experience a migraine, and almost nobody rated as a low pain experience. Similarly to constipation, there was almost nobody who said that there was no pain associated with constipation. There was always a low-level pain to a we're rushing to the hospital type of pain experience. And I think that's really telling of this population. And what I see from these 2 pieces of data is that not only do we have acute and chronic conditions, but that we also have some conditions that are much more intense. And if you are looking at something like that gastroesophageal reflux, that was about 170 days a year on average that it occurred, and at least our average rating here, according to our pain intensity, was parents rated that as a 2 out of a 0 to 4 scale for the amount of intensity of pain that associated with, which to me says these are probably the first areas we need to target for treatment, and that we should probably be looking at when we suspect a painful experience for an individual with Charge as well. The last thing I'll note on this slide was that on average, the number of children in our sample that sample was under the age of 18, they had on average had 13 major medical procedures. And that ranged from one child only having 1 procedure to another child having up to 63 major medical procedures that required hospitalization. Again, if you think about that in terms of the duration of pain experience and the intensity of pain experiences, we have a lot to learn even related to surgery pain, particularly for this population where they spend a lot of time in the hospital. What we also found when we ran our data was that there was a tendency for the intensity of pain to increase for short durations of pain compared to longer durations of pain. And I think that makes sense in terms of just how you and I might experience pain, is that if I slam my finger in the car door, that's going to be a very intense, painful experience short term. And that pain experience, while it's still going to be there over the next week as my finger heals and my hand gets better, that's going to be a lower level experience of pain as it's healing. But the immediate insult and injury will result in the highest duration or highest intensity of that pain experience. And we saw that type of experience as well with our Charge population, which came as no real surprise to us. So let's move into how you might identify or measure pain in this population. And I think this is really valuable for parents. This is really valuable for educators. This is valuable for other professionals like our therapies and our therapists that work with us. And I think this is also really valuable for us to continue to do more research on. So let's dive into how we might consider identifying and measuring pain in Charge. So what are some of the difficulties? I highlighted this briefly. First off, one of our greatest areas of difficulty is that lack of self-report. If you don't have a particular word for pain, you've not understood what that this feeling means, whatever language we want to place with it, like the word pain or boo-boo or ouchie, then you're not able to self-report that experience. So that's one of our greatest obstacles, is we need to be teaching communication approaches of how to identify this pain and show a part of our body. And so teaching body parts, teaching about in the moment when pain happens, using that as a teaching opportunity to discuss pain and to label what that feeling is going to be really valuable. And I think we take that for granted in most kids, is that they pick that up abstractly in their environment. It's great social learning, but we have to be much more explicit about that when teaching this to individuals with charge. And so that's our first obstacle, is being unable to self-report their pain experience. As I mentioned, facial palsy has a limitation in our facial recognition of pain, which is really common for us to make note of. Even across the room, we could look at somebody and surmise that they're sad or might be uncomfortable. So what we have had great advancements in are what are called multidimensional pain inventories or pain assessments. And what those assessments look at are multiple parts of the body, including those facial reactions, but including changes in behavior, changes in how the body reacts to that painful experience. And these have been much more valuable for us to get a more comprehensive picture of pain and charge syndrome. So there are a couple of different ones of those on the market. There's something called the Non-Communication Children's Pain Checklist Revised, and this is a great, well-validated instrument. We were actually able to use this in part of our study to identify pain for this population. They also do have an adult scale, which is really helpful because obviously our behaviors and the way we express those behaviors of pain may change as we age. There is the Pediatric Pain Profile, or the PPP, is also a wonderful tool to track pain over time, to try to get a baseline of what behaviors look like for that child that might be pain related. Some of these are really helpful and some are not appropriate. Some load very heavy on facial recognition, and with that facial palsy is not very helpful for us. And some don't include behaviors that we have seen elevated in charge, like that self-injurious behavior, aggression, or destructive behaviors that are really we mislabel them as aggressive or challenging behaviors. They're really just bids to get access to your support so they can feel better. If I become aggressive towards you, I'm really just trying to communicate to you that I'm uncomfortable. So we have to kind of change our mindset. Is this a behavior that's challenging that we need to work on in the environment, or is this a behavior where the child's trying to communicate to me something's wrong or something needs assistance? And when those behaviors come out of nowhere, that's a really clear indicator that we should be looking at what's happening in the environment, and their body is a really important part of that environment. So what we had done with this study was we had parents complete the non-communicating children's pain checklist and the pediatric pain profile, and we had them complete that on days their child was having a really good day, days that we wouldn't expect them to be in pain. And then we also had them complete it on days that they saw a painful incident occur to their child, whether that was a surgery, they were diagnosed with an ear infection, they accidentally hit their hands in the car, those types of things. What we found was that some items had a very clear distinction that were highly elevated when there was a painful experience, and some items showed no change at all from baseline. So we knew those weren't the items for our population that we were interested in, and many of those were the facial items that would change for other populations but weren't changing for charge as a result of that facial palsy. So we took those items, as well as items that parents highlighted for us were ways that they noticed their child was in pain. And we created what was called the Charge Non-Vocal Pain Assessment, or the CNVPA. And so you might be able to see that on your screen now. It is a couple of different items that are broken up into a couple of different scales. So we have vocal, social, facial, activity or challenging behaviors, and then body or limb or physiological changes. And what we asked parents to do for this scale as we move forward with validating it was to rate their child again for baseline when their child was having a good day, what kind of behaviors do we see, and then again rate it again when their child was experiencing painful behaviors. And so we had them rate from 0 to 3, meaning I don't experience this behavior at all the way to I experience this behavior a great deal as a number 3. And you'll see that we have things like cries, moans, we have being sociable or responsive. We expect those things to decrease as individuals with charge are experiencing pain. We have a very social population for individuals with charge. They like to be engaged. They like to be around other people. The fact that they withdraw could be an indication that maybe there's a painful experience happening. We look for things like some of those facial changes of the mouth turning down or screwing up of the face or forehead. But really what the meat of our scale was adding in the activity and challenging behaviors. This is something that I think is lacking on some of the other non-vocal pain assessments, that we did not see these behaviors as clearly in some of those other scales as what we found, a very clear distinction between baseline and painful experiences for individuals with charge on this scale. So that does include being restless or agitated, self-injurious behaviors, becoming aggressive, changes in sleeping and eating patterns, resist being moved, and even an increase in OCD-like behaviors. So what we mean by that is, as we see anxiety increase, we see children with charge have a need for more order, more repetition, more clear schedules that they like to have. And while some of that is really valuable just for your day-to-day, when there seems to be a spike in those behaviors, that could also be another indication of pain, a way of trying to cope with that experience. So really we see an increase in anxiety-producing, or what would look like anxiety-producing behaviors. So this was a scale that's freely available. You can find it online. You could always reach out to us. We'll have it available to you as well. But this is a scale that I encourage parents to use, and educators and other folks. And from what we found, it seems to be a pretty reliable and valid scale. We do need to have more investigations of this scale, and I'll talk about that a little bit. So we did see a strong reliability, like I had mentioned, differences between no pain and pain days. And what we really thought was valuable for the validity of our scale was about 40% of our participants were able to confirm with a physician that their child was experiencing some type of physiological change that would indicate pain, like an ear infection or a clear injury like a break of a bone, those types of things. And so that gave greater validation to the fact that not only do the parents believe that this looked like a painful experience, but that then we were able to validate that was a painful experience and document that in their medical record as well. So when we saw the charge non-vocal pain assessment and all the data come together, what we found were some really significant items. And it seems like this is a pretty lengthy list, but I think these are our top behaviors right now based on the current research of what we need to be paying attention to with charge syndrome. So we saw them become not cheerful, become aggressive, remove themselves from social situations. We saw the furrowed look or looking worried. They become less active or quiet in many environments. We see a change in eating. We even have seen some kids who are only tube fed try to refuse the tube feeding altogether when they have experienced painful situations. We've also seen some kids attempt to remove their button or remove their tube to relieve gas in that area, again suggesting that that's a painful experience. Some kids have developed very sophisticated movements to indicate pain that their parents were able to describe to us. That, for example, we had one parent describe that when their child had an ear infection, they would take objects and just sit them there and lean their head against them. They wouldn't really associate any other behaviors with that, but they knew as soon as their child was placing objects at their neck or ear and pressing that down, that that was an indication of a potential ear infection for their child. And often they would take their child to the doctor and that would be the outcome. We also saw that they become not cooperative in following rules or directions, and their general day-to-day behaviors are opposite of what they would be in a more cooperative setting. And we see sometimes a change in color and sometimes temperature dysregulation as a result of a painful experience as well. So I think right now these are our most significant items to look for on that pain scale, but also are valuable for us to consider when we are working with individuals with charge or part of individuals with charge lives, that if we see these behaviors start to happen, one of our first thoughts should be pain. Certainly they could happen for another reason as well, to communicate something differently, but I would much rather rule out pain first and then be able to move forward with what else could be coming next. So we were improving quality of life and making sure the treatment was able to happen as soon as possible. This is our differences by age, and this is what I think is really where we need to spend much more time with our research and know a lot more about how pain changes over the lifespan in charge. And we have a lot of research that we need to do to better understand the lifespan of charge in many other areas. But I think given that pain is such a common experience, particularly when children are young, that we've kind of forgotten what it's like to look at pain for adolescents and adults and what those behaviors might look like. Even if they've developed a more formal communication system and can self-report their pain experiences, how might that impact other behaviors or their overall quality of life that we need to be better cued into? So what we did find in our population was the behaviors you would expect for under the age of 5, the things that most parents look for when a child can't tell you they're in pain. So changes in eating, they become less active, and they have a change in color. Those were all very common behaviors that we saw on our pain scale. However, as we moved into the adolescent years, what we actually saw was a lower mean difference on aggressive behaviors and grinding of teeth. So that suggested to us that when those behaviors spike, this is likely an age where we've developed better communication styles to be able to self-report our painful experiences. However, in adults, we saw a number of different items, ages 26 and up, where we saw turning their mouth down, an increase in self-injurious behavior, disturbed sleep, resisting being moved or touched, and even holding a specific part of their body to indicate pain, like their head or their arms or their legs. And these might be helpful indicators for us to kind of think about, depending on the age of the individual with charge that you are working with or is a part of your daily life, that could be factors to consider based on the different age. But again, we need much more research in this area, and knowing the pain experience throughout the lifespan and how we can better adjust that, and even what the different symptoms of pain might be throughout the lifespan based on the medical changes of an individual with charge throughout their life as well. So what I urge folks to do to best use this scale at the moment, until we have more investigations and until we have better research knowing what this looks like by different age groups, would be to take this scale and take several days where you feel like your child's having a really good day, or your student with charge is having a good day, or whomever you're working with, and have some baseline of what are behaviors that are just kind of common on this scale that your child does. Those won't be good indicators for you of painful experiences. But the ones that don't show up at all, but suddenly show up when your child's in pain, could be really helpful indicators for that child or that student that you're working with. So I encourage you to have a baseline level of where you think the child's not experiencing pain, but when you suspect pain to happen or you know pain will happen, take the ratings again multiple times to see what your average score is, and we'll see what the differences in those items are between that baseline experience and the pain experience. And so as you can see in the sample graph that's listed here, if your no pain scale is separating from your pain scale, that gives you an idea that those items might be your greatest indicator for that child of a painful experience. And maybe it's only 3 or 4 of those items that work for that child or student with charge to better identify pain. But to track that over time to be able to see those changes, and that could be really valuable for your healthcare team, but also valuable for you to start seeing even patterns and change in behavior. For example, I had a family that I worked with who did this over several months, and we were actually able to predict the menstrual cycle about to start for their child based on when those behaviors started to elevate right before the menstrual cycle happened. And then they were able to provide treatment that was preventative before the pain experience even happened. And it had a huge difference in the reduction of self-injurious and aggressive behaviors that would spike on that same cycle around the same time each month. All right, so let's talk a little bit about how this experience could impact and have an impact on other challenging behaviors that you see present for an individual with charge. So the first thing to keep in mind is all behavior serves a purpose. I think that we sometimes get trapped in this problem behavior must exist for some unknown reason that we can't solve, and we try to make it very complicated. But every behavior we engage in, whether it's appropriate or inappropriate in the social context, serves a purpose for what we're doing. And all behavior is learned. It becomes reinforced, and that pattern of reinforcement maintains that behavior over time, or it becomes punished and we stop learning that behavior or doing that behavior. So when we think about challenging behaviors that might exist in charge or really in any population, we need to think about behaviors communication. All behaviors are learned, and all behaviors serve a purpose. And really, behavior is an interaction that involves the environment. So you see this in kids all the time, in that their behavior changes based on what environment they're in. They might have wonderful behavior at school, but come home and have miserable behavior with their family. That might be reversed. They might be a child who always has wonderful behavior in most settings, but the environment helps to influence the impact of that behavior or reinforce that behavior. And when we think about something like pain, our body is considered a part of our environment. So what I often hear is that folks like behavior analysts or folks who think from a behavioral viewpoint aren't considering pain or these other sources of impact from the body, and that's ill-advised. Actually, they're very concerned about what's happening within the body and to the body in that environment, and a painful experience inside of us is still a part of our environment that impacts our day-to-day. And so it might be difficult to pick that up in some situations because your behavior may look very different depending on the context or environment that you're in. But one of the first things we want to do when we consider pain is consider, is this a behavior that is simply changing as a result of the environment that we're in, or is this a behavior that's occurring in multiple contexts of the environment? So, for example, if a child were to engage in no problem behavior at home, come to school, engage in no problem behavior, but the moment math is presented to them in class, you see a spike in problem behavior. And let's say that's at 1 p.m. If that child is repeatedly tracked with data, every time that 1 p.m. hits, we see an elevation of behavior, that's not likely a painful experience. That's likely a result of the environment, which is, I don't want to do the math and I want to try to get away from this, so I elevate my behavior to get away from that. But if there was truly a painful situation that was a chronic or persistent pain, you would tend to see that at home, on the commute to school, while at school, and throughout the school day that might look very different than what their average school day would look like. So again, we have to think about the environmental context and how the body would change as a result of that. Now, if I'm highly distracted doing something I really love, maybe I'll kind of forget about that painful experience a little bit. But when those activities dissipate and I'm sort of re-reminded of this painful experience that's happening inside of me, you might see those behaviors elevate. So we have to kind of tease apart some of those things in the environment, and sometimes a good behavioral specialist can come in and help us do that. So when we want to break down the basics of why any behavior happens, whether it's a challenging behavior or a behavior that we love and we hope all kids do, we have to think about why behavior happens. And so what's the function of that behavior? And we make things much more complicated when we try to say why a child did something or why we as adults do something. It really boils down to, we want to get access to something or we want to escape something. So I might want to get access to tangible items, things that I can hold and touch and have. Maybe it's my tablet. Maybe it is my video game. Maybe it is my favorite candy that I love. But I want to get access to that thing that I can hold and have a tangible product with me. I might also want to get access to social attention from somebody, whether that's my classmates, whether that's my parent or teacher. It might even be my nurse at a hospital. I worked in a hospital setting once where we had a patient that kept reoccurringly coming back complaining of all these complications, and we repeatedly could never find what was happening. And we found out that they just really loved the attention they got from their nurses and the doctors and the folks on staff at that hospital, that they would almost make up these stories to be able to be entered back into the hospital, because that was their access to social attention, and they did not get that in the same way in their home or other environments that they were in. environment. So we want to be mindful of that, but we all want social attention. That's why we have partnerships and relationships and those types of things. So to get access to that. Another area we might want to get access to is internal stimulation, things that make us feel better. And I'll talk about that in just a moment. Our other function of behavior outside of access to something is to escape something we don't like or something that we might find aversive. So I might want to escape a tangible item. I might want to escape that math worksheet that was just presented in front of me, or you gave me a meal that I really don't like and I want to escape that tangible product. I might want to escape attention. I work in many schools and I have students who are very shy who might get called to the front of the class to be given kudos or praise for something that they've done. And actually that child would much more likely to escape that situation than to receive that praise in a public format. So we might want to escape